Endoscopic endonasal surgery, which was initially started for the pituitary surgery, has been extended to the paracellular region, cavernous sinus, extracellular region, and the covering the anterior skull base as well as middle skull base. These endonasal approaches to the ventral skull base are classified according to the orientation of the sagittal and coronal plane relative to the sphenoid sinus. Sagittal plane surgery include frontal sinus to the sella, from the sella to the upper cervical span. This is the sagittal plane. And coronal plane extend laterally, and it corresponds with the each cranial fossa, anterior, middle, and posterior cranial fossa. The anterior cranial extend from the sella to the posterior table of the frontal sinus in the midline and laterally across the orbital roof. Discrete sagittal plane module include transfrontal, transcubiform, and transplanum approaches. So, anterior skull base extend from the posterior table of the frontal sinus up to the anterior clinoid process or sphenoid ridge. Middle cranial fossa extend from the anterior clinoid process to the posterior clinoid process or up to the dorsum celli and laterally up to the petrous ridge. And posterior cranial fossa extend from the petrous ridge or dorsum celli up to the protuberance, that is occipital protuberance, or you can say the occipital crest posteriorly. Classification of endonasal approaches to the skull base in sagittal plane, starting from anterior to the posterior. First approach is transfrontal approach, second is transcubiform approach, third one is transplanum approach, fourth one is transcellular approach, fifth one is transclival approach. These are divided into superior, middle or inferior clivus approaches, and last one is transodontoid approach, that is craniovertebral junction approach. These are the sagittal plane approaches. Now coronal approaches are according to the anterior cranial fossa, middle cranial fossa and the posterior cranial fossa. Anterior cranial fossa approach are supraorbital and transorbital. Middle cranial fossa approaches are medial cavernous approach, medial petrous approach, suprapetrous approach, infratemporal skull base approaches. And posterior cranial fossa approaches are transcondylar, infrapetrous and parapharyngeal space approaches. Indications for endoscopic endonasal surgery. Transfrontal approach mainly used for chronic sinusitis, mucocele, osteoma, nasal thermoid. Transcubiform approach used mainly meningoencephalocele, olfactory groove meningioma, olfactory schwannoma, olfactory neuroblastoma, and sinonasal malignancy. Transplanum approach or supracellular approach mainly used for pituitary adenoma, craniopharyngioma, meningioma. Transcellular approach mainly for pituitary adenoma, Rathke's cleft cyst, craniopharyngioma. Supraorbital approach for the osteoma, meningioma, and sinonasal malignancy. For sinonasal malignancy that involves the cubiform plate with risk of intracranial extension along the olfactory filea or the olfactory valve. In that case, we required bilateral wide resection of the anterocranial base that include dura, olfactory valves, and the olfactory tracts. Transfrontal approach provide access to the skull base anterior to the cubiform plate, and draft 3 procedure is the main procedure in this. Limits are anteriorly anterior frontal sinus table, posteriorly posterior table of the frontal sinus, medially crista galli, laterally lacrimal fossa, and superior limit is the posterior table midpoint. And these approach having key structure like foramen cecum, crista galli in frontal sinus. Transcubiform approach provide access for tumors that arise from cubiform plate area such as olfactory neuroblastoma, olfactory groove meningioma. It also a common site for the meningoencephalocele with spontaneous CSF leak. Limits of this: anteriorly posterior table of the frontal sinus, posteriorly planum or posterior ethmoid artery, medially crista galli, and laterally the orbit. These are the limit of this cubiform approach. The anterior and posterior ethmoid arteries are best transected on the orbital side of the skull base. The bone of skull base is then thinned out with the drill and elevate the exposed dura to the margin of the dissection. If dural margin are important, it is helpful to elevate the dura from the orbital roof. This makes easier to resect additional dural margin for the oncological clearance. The base of the cresta gala is removed with the drill prior to dural opening so that attachment of forks can be cauterized and cut once the dura is open. Transplanum approach provides access from the cubiform plates anteriorly to the tuberculum posteriorly. The planum forms the roof of the sphenoid sinus and bounded posteriorly by the optic canal. Limits are anteriorly cubiform plate, posteriorly superior intercavernous sinus, posterolaterally optic canals, and lateral will be the orbital apex. So, this transplanum approach sometimes isolatedly used for the intracranial meningioma. It may be combined with a cellar or supracellar approach for the lesion of supracellar lesion like pituitary tumor or craniopharyngioma. Posterior ethmoid arteries are variable in location and diameter but generally found near the junction of planum sphenoidally with the roof of the sphenoid sinus. The foramina are approximately 4 to 7 mm anterior to the optic canal. Supraorbital approach is a coronal plane approach that provides access to the orbital roof. The maximum limit of the exposure will be mid-sagittal plane of the orbit. This approach mainly used for the osteoma and meningioma tumor removal. Limits of this approach are anteriorly frontal sinus, posteriorly optic canal, and supralaterally midplane of the orbit. It often combined with transcubiform or transplanum approaches. The supraorbital approach is bounded anteriorly and posteriorly by the ethmoid arteries. Following a complete sphenoethmoidectomy, the medial wall of the orbit is removed up to the level of skull base. The anterior and posterior ethmoid arteries are identified and transected following cauterization. Supracellar approach is combined with transcellar and transplanum approaches to gain access to supracellar pathology. The most common indication include pituitary macroadenoma with supracellar extension, craniopharyngioma and meningioma. It is bounded anteriorly by the optic chiasma and posteriorly by the pituitary stalk or membrane of Liljequist, and limits will be anteriorly planum sphenoidally and laterally optic canal and paraclinoid ICI.